Great. Good morning. Thank you, Twyla, for that kind introduction. And thank you, Dr. Manley, for providing the overview of where we are headed into, I think this was your actual last slide, which is a golden age in traumatic brain injury. I'll be providing some of the evidence behind what Dr. Manley went over. And a lot of this is kind of review. It's been around for the last 5 to 10 years, but some of this is new, and I think that is very exciting for us to be able to hopefully implement in the coming years. Okay, so this is a review for everyone. So traumatic brain injury, big problem, probably over 2 million annual injuries in the United States, over $84 billion of direct and indirect costs. It's a bimodal injury with, younger patients as well as older patients from, I think, high impulse activities and, incidental falls, I think, respectively. And over time, there's increase in seeking traumatic brain injury care in the emergency departments across the U.S. Is that because more people are getting injured? No, I think it's because more people are understanding that TBI is a problem. So as more people enter the healthcare system, how do we deal with it? And I think there needs to be an effective and efficient way of triaging and diagnosing patients and getting them to the care that they need. Different forms of traumatic brain injury, of course, are present. You can have coup and contra coup injuries, you can have rotational injuries, you can have shear injuries, you can have blast injuries, and all of those present with the different types of biological injury that Dr. Manley had talked about earlier. So we need better ways of characterizing what these injuries are, and specifically the lesion type, location, volume, eloquence of the brain region being injured, and how they progress over time and interact with each other. Definition of mild traumatic brain injury, we won't go over this. Historical challenges, people know, I think here in the audience, there haven't been any successful medical trials or therapeutic trials for traumatic brain injury in terms of giving drugs. However, I think we have several trials right now in the ICU and in the hospital that are testing this, so this hopefully can be revised in the future. Part of the reason why there hasn't been a successful trial is due to, I think, the heterogeneity of patients, as well as crude measures of assessing their inclusion and crude measures of determining their outcome. Inclusion based on GCS scales obviously is, starting to become obsolete, and dichotomized outcomes to measure the endpoint success, such as using the GOSE of good or bad. Well, we just heard from Dr. Manley that good or bad is probably dependent partially on the injury severity itself, and also partially on the patient's outlook and the family's outlook on what is good versus bad, and what is definitively and objectively good or bad based on the clinical measure. So those things are different, and you can't really just dichotomize based on one single measure of outcome on what's good or bad. So I think these are the reasons why there haven't been successful trials. So this is a GOSE, this is what we use, and still the only FDA-approved measure for traumatic brain injury outcome. And as you can see, it's a functional outcome measure that spans dead to full recovery. 2 is vegetative, 3 and 4 are basically you're unable to kind of leave the house or enter society without some level of help. 5 means that you are able to leave the house but unable to go back to work. 6 is that you're able to work to partial capacity. 7 is that you're able to work probably to your full capacity but unable to resume full recovery. Basically, you've got post-concussive symptoms. And 8 means that you're perfectly back to baseline. Well, that's a huge gradation that is somewhat subjective and based on function. And if we have if we have clinical trials that are based on this as an outcome measure, well, depending on where you cut it and what kind of patients are being selected to enter the trial, this is why some trials haven't worked. This is why most trials haven't worked, actually. And we know about the GCS, right? The classification systems are a little bit insensitive. However, what we've found in recent studies, which I'll go over, is that the motor score is probably most predictive of one's outcome because it's most correlative with the descending motor tracts and descending levels of consciousness. So, a 1-point decrease on the motor score is different than a 1-point decrease on the verbal and the I score, right? If somebody has a 1-point decrease on the motor score in the ER, that person is probably getting an immediate head CT and heading to the ICU and getting a neurosurgical consult. But this is also why the GCS as a sum score is probably not as important as the GCS broken down into its reported elements, which is what we should and should keep doing in terms of our in terms of our reporting systems. For acute intracranial findings, we talked about this earlier. Head CTs are the gold standard. However, we need to get better at talking about the lesion type, location, and volume. Mass effect, midline shift herniation, yes, those things are present, but how do we quantify them in a way that is reportable so everybody understands it? I think we have ways of doing that. And the purpose of this talk a little bit more is talking about blood-based biomarkers and imaging biomarkers and how they may integrate into our current diagnostic and prognostic framework for traumatic brain injury. We'll skip over some of these history things, but this has been, kind of developed since 2009 with the inception of the TRACK TBI study, which is based on data standardization from the NIH. We used 4 large domains from the multiple white papers at that time: demographic and clinical information, biospecimens, biomarkers spanning genomics and proteomics, neuroimaging biomarkers and outcomes, which you can see here on the right. This is kind of where a lot of the TRACK TBI work has been has sourced from over the last 12 to 13 years. So initially, we collected this data and we showed that there was value in data standardization. And furthermore, is there value in using these common data elements to help with diagnosis and prognosis? And we found that, yes, that is true. We've built a data warehouse back then, and that data warehouse has now been extended and replicated and adopted by all of the different clinical trials that we do. And we found a lot of promising results across all of these domains, and probably had 70 papers from TRACK TBI pilot and probably over 100 papers from the current TRACK TBI study that is ongoing. So this, I think, is still the hallmark of a lot of our talks. This is now from 2013. It's the first TRACK TBI paper that was published. And we looked at mild TBI, so GCS of 13 to 15 patients who had a negative head CT. And it turns out that 27% of them had a positive MRI. So, they're getting told probably that most of these people, if they didn't have an MRI, would be told that they don't have any injuries in the head CT. And if they don't have a ton of neurodeficits, probably discharged from the emergency department. Well, it turns out that they do have injuries in their brain and they do have traumatic brain injury. So what are those injuries? Small contusions and axonal shear injuries, and probably small, subarachnoid hemorrhages that aren't detected on CT. Well, as you can see there, these are the predictors for outcome as well. So maybe this is the missing link between structural brain injury and outcome. Well, it is structural brain injury, right? So how do we find these people? And do we get MRIs on everybody? That's probably not feasible, but we can probably find a way of doing this, such as having a good follow-up system for patients and ensuring that, if they're symptomatic, that there's a framework where they get care and potentially get an MRI that may show a higher risk of getting these lesions and getting the care that they need afterwards. Moving forward, biomarkers, again, this is from work over the last probably 30 years now. We've shown that glial fibrillary acidic protein, which is a glial protein that's measured in the blood after traumatic brain injury due to permeability of the blood-brain barrier. If you've had structural brain injury for a brain-specific protein that leaks out into the peripheral circulation, there's probably, that's probably good enough evidence that the brain injury has occurred, right? Otherwise, that protein wouldn't be in the blood. So GFAP correlates very well with presence and absence of injury. It correlates very well with the number of head CT lesions, with the severity of brain injury. And we've also looked at, autoantibodies to GFAP to see if there's an autoimmune hypothesis. And, different people who've had brain injuries before do have autoantibodies to GFAP. Now, what do they do and where do they go? That's a good question that deserves further investigation. So, how has this been adopted? Well, this is now 2014 to 2018. We've implemented the common data elements. We've shown that there is utility. We've expanded their use, and we found that there's even more utility in capturing this and developing better prognostic models and better ways of diagnosing patients. So we enrolled 3,000 patients in TRACK TBI, 7,000 patients in Europe for a power sample of 10,000. And we're going to go back to imaging here. So you saw this picture from Dr. Manley's slide. This is one of the first papers that came out of the 18-center TRACK TBI study, as well as the 65 center TBI study in Europe. These patients may all have similar presenting GCSs. However, the care for them is quite different. So On the left here, you have epidural hematoma that can probably be taken out with a good chance of recovery. Subdural hematomas can be taken out, maybe observed, need anti-seizure medication, and they may not do as well. Contusions, we usually don't take them out here in the U.S. unless they're huge. Some centers do take them out, and they're going to swell, and the patient's going to be in the ICU for a little bit potentially. Subarachnoid hemorrhage, you can't evacuate that surgically, but we've seen that is a persistent predictor to poor outcomes. Well, why is that? Because it causes some, cortical inflammation and circulates through the subarachnoid spaces, and actually is a predictor of lesions that are adjacent to that area that may be intraparenchymal. You've got intraventricular hemorrhage, usually from some high degree of rotational shear that injures the periventricular veins, and that causes inflammation. And then you've got petechial hemorrhages there, or axonal injuries that usually can't be seen on CT, but yet do a lot of it makes you essentially disconnected from a network perspective. And those people don't tend to do as well over time. So 6 different injuries. These can be in conjunction with each other, they can be all combined. We've certainly seen people with all 6 injuries at the same time. And the way to take care of these patients are, certainly different depending on the brain pathology. So, when we aggregated tract TBI and center TBI, we saw that isolated subarachnoid hemorrhage, which is the highest bar in the upset plots there on the right, is the most common injury across both studies. Well, it's the most common injury, and a lot of centers here in the US would say, if you get isolated subarachnoid hemorrhage and you get a repeat head CT and it's the same, well, that person can probably be discharged, and they don't need AEDs, right? And do they need follow-up? Well, we know it's a poor predictor for poor outcomes. We know that's very common. So, how do we link that? Well, I'll show that a little bit later here, but it is important. You're moving forward here. So biomarkers, so taking us a little bit backwards in history here. This is probably, I think, now close to 5 to 10 years ago, where GFAP and UCHL1, which is a neuronal protein, were first qualified by the FDA to be able to have discriminative power for head CT presence or absence, or presence or absence of intracranial injury in head CT. So this was back in 2014, right? This is from the ALERT TBI trials, about 10 years from now, or 10 years ago, where we first qualified the use of these biomarkers. Now, at that time, this was a benchtop test that required 3 to 4 hours to come back, which might be a little too long if you're going to use it for acute TBI diagnosis in the ER. However, what they showed back in 2014 was that GFAP and UCHL1, when used together, have a negative predictive value of over 99% for presence or absence of intracranial lesions on a head CT. It's pretty good as a rule-out test. So, it works for CT. Does it work for MRI? So the first study that we showed where, 27% of the patients who have a negative PET CT have a positive MRI. Well, can the biomarkers be useful for that, right? For screening purposes, for triage purposes. Say that your biomarker level isn't super high, but it's a little bit elevated. Can you triage that person to get an MRI as an outpatient or as an inpatient if they're staying? And, how good is that, right? So we looked at, from the tract TBI study, patients with GCS of 13 to 15 and a negative head CT. And, of course, about 25% of them had a positive MRI. And we used, this was a handheld test and looking at plasma values of GFAP. And what we found is that, yes, it's actually pretty good. So all of these patients had a negative head CT, right? The area under the curve, or the discriminative power for GFAP, was 0.78 overall for MRI positive lesions. And if you look at when you use this from the time of injury, the area under the curve was actually the highest between 9 to 16 hours at 0.852, which is very, very good. The AUC of procalcitonin for pneumonia in the ICU, I think is below 0.7, and we use that as a test, right? So this is quite good actually. And if you look at what kind of injuries it's capturing, on the MRI, you see that highest box plot there is diffuse axonal injury. These are the injuries that can't be seen on CT, right? You need to get an MRI to see these well, but an MRI is expensive and time consuming. A blood test you can capture, in a much less time consuming and expensive way, with certainly a lot less contraindications. So if you look at the medians there, the numbers are a little small, but A positive head CT has a median of 800 for GFAP value. A negative head CT has a median of 100. This is why Jeff had said 100 was kind of like the cutoff for being abnormal here after on GFAP testing. If you have a negative CT and a positive MRI, it goes up to 400, right? So there is a threshold basis to this, and there's a severity basis to this. If you have a negative head CT and negative MRI, it's 74. If you have an ortho control or a healthy control, it's 8 to 13, right? So there is certainly a structural objective basis to this. And in going forward here, this test, or biomarkers in general, there's many forms, right? There's structural proteins that are released after blood-brain barrier damage, and those are kind of like within minutes to hours there. You've got neurodegenerative markers that rise later on. You've got apoptotic markers, which are inflammatory markers that rise even later on. You've got autoimmune, markers that arise in the chronic phase. So how do we put all this together? There's a lot of, we're doing actually a lot of work that's actively synthesizing this and seeing how these markers can work together for primary and secondary injury. So finally, I think in looking forward here, is GFAP and UCHL1 prognostic? Well, they are prognostic. They're certainly very good at ruling out, discriminating deaths versus alive. And they're also good at, determining, who has an unfavorable outcome, meaning that their GOC is 1 to 4, they can't leave the house and they're dependent for some level of their ADLs versus non-dependent. But that's because it's based in, structure and function, right? If you have more brain injury, you're probably going to be more disabled. So, how do we make that better and how do we make that more sensitive? We're going to skip forward here and looking at some subarachnoid hemorrhage studies. This is from the TRACK TBI study where we looked at patients with isolated subarachnoid hemorrhage, and 47% of them actually had an additional finding on their head, on their MRI, such as subdural hematoma or axonal injury or contusions. And GFAP was actually, able to detect these. So people who had isolated subarachnoid hemorrhage versus people who did not, or people who had an additional lesion on top of that, the area in the curve was actually around 0.7. So it's actually pretty good at even looking at people with positive CTs and additional lesions on their MRI. So we really should think about how to integrate their use in moving forward here. And this is kind of one of the take-home messages here. If you got isolated subarachnoid hemorrhage and no additional abnormality on your head CT at 2 weeks, again, 25% of them are back to work, but certainly much higher than 4% of them back to work if you have an additional lesion, right? And at 3 months, if you had no CT occult lesion on your MRI, your GOC of 5 to 6, so aka not being able to go back to work, is 12%. And if you did have a CT occult lesion on top of your isolated subarachnoid hemorrhage, your chance of not going back to work is close to half. So there is a structure-functional relationship, and isolated subarachnoid hemorrhages are frequently discharged again from the ER and not admitted, but they don't do very well, right? So that's because there is a higher chance of them having an additional lesion, and we should find those people and take care of them better. So I think in putting everything together moving forward, there's a lot of scoring systems for TBI diagnostics for prediction of alive versus dead, prediction of functional recovery versus not. They're crude, and how do we make them better? Well, we've shown in some of the TRACK TBI studies recently that if we use these, the impact and crash scores, which are prognostic modeling scores over the last 20 years, we've shown that in our current studies here on the top there is for mortality. So that red line is higher than the actual data line, which means that we are actually we're actually kind of like under predicting let me think, what's the word here? We're over predicting mortality in the sense that our actual mortality is less than what the data would show. But here on the bottom right here, we are accurately predicting their unfavorable outcomes. So does that mean that we're not doing a good job? No, I think what it shows is that we're getting better at taking care of people over time. We are saving more people. Their outcomes are as predicted, but how do we make their outcomes better? And I think that depends obviously on integration of the new data that we have, namely blood-based biomarkers, MRI imaging, volumetrics, et cetera. Okay, thank you very much for your time.